Welcome again to the JHWiki Virtual Toolkit series. As you know, this is our Part D Signature Toolkit series or program with the purpose of engaging and amplifying. My name is Allison Agua. I'm a program director of this program and a professor of adult and peds infectious diseases at Johns Hopkins of Baltimore. In terms of our program, the JHWiki stands for the Johns Hopkins Medicine Collaboration with Women, Infant, Children, and Youth for HIV Excellence across Central Maryland. We're a combination of 6 distinguished programs here at the Pediatric Adolescent HIV/AIDS program, the Hopkins Women's Program, Sinai Support Services, University of Maryland's HIV program, as well as the Emerge Clinic at Johns Hopkins and Psych Services. And the goal of this is to build a more coordinated approach and response to caring for the wiki populations by really building upon our mutually beneficial relationships that increase the quality of care that we provide as a whole community, build on the structures that we have, and actually present a coordinated network of wiki providers across the region. And the goal of this series and everything we do is to engage and to amplify experts. And so with that pause, I want to say we're all experts. And so if you see something and want to say something, we are really looking forward to have you sharing what you know and what you do. And we are funded by a HRSA grant number there. Today, I think the word is ecstatic. I'm going to go with ecstatic to have Dr. Ronald Means present today. And you see his topic here. But first, I want to brag a little bit about Dr. Means, who I met while we were both onboarding our kids at GW, where they were both going to be freshmen. Dr. Means is a board-certified psychiatrist in the fields of both general psychiatry, child and adolescent psychiatry, and forensic psychiatry. He completed his training at University of Maryland, where I also did my training, and Johns Hopkins Hospital, and holds faculty appointments at both institutions. He previously served as the Chief Medical Officer for Catholic Charities of Baltimore, where he was responsible for both treating and monitoring the treatment of children and adolescents and adults with mental health and substance use disorders, as well as supervising and evaluating the competency of that clinical staff. Currently, he's Chief Medical Officer and staff with Sheppard Pratt, where he oversees psychiatric staff, providing care in community and school-based settings. He also, as if he needs more to do, assists in developing and implementing policies and procedures to ensure safe, effective clinical care, and also maintains a private practice focusing on forensic psychiatric evaluations of both children and adults. And so with this month being basically youth mental health awareness, we thought no other perfect person to present on this topic of youth behavioral health problems and STIs, prevention and treatment, than Dr. Ronald Means. Dr. Means, please take it away.
Thank you so much. Thanks for the introduction. So just to give you a little snippet of why I was asked to come and speak. I spent the vast majority of my time when I was the Chief Medical Officer at Catholic Charities working clinically in youth crisis services. So for Baltimore City in particular. So we managed the youth crisis program for Baltimore City and had the opportunity to treat a number of youth in crisis. And certainly having awareness of somatic care for the kids that we were seeing, but in particular, trying to prevent these poor outcomes that many of the kids who have co-occurring mental health issues as well as high-risk behaviors was a large focus of the work that we did. And understanding STI prevention and educating those that we served was a huge part of the work. So hopefully I can bring together both of those areas and help everyone understand how the areas combine. So let me share here and I'll get started. Hopefully that looks good to everyone. Please yell out if there's any concerns about.
You can see all the things.
Great, thank you. And this is, I'm hoping to be informal. I hope I'm not breaking the mold of what happens here, but I want this to be a informal discussion there. And if you have questions along the way, please unmute and yell out, and hopefully we can get some audience participation for portions of this as well. But today, I'm here to talk about youth behavioral health problems and STIs, and talk about prevention and treatment. I want to give a good layout of here. It's advanced. There we go. I want to give a good layout of what it's like for community behavioral health providers and helping you understand some of the complexities of both the youth that we see, but also how we provide care for them, and then how we work ideally to manage those kids that we see in terms of preventing acquiring STIs or treating those who might have STIs, as well as mental health issues. But in order to lay the groundwork for that, I wanted to talk first about the idea of adverse childhood experiences. And I'm assuming that majority of folks on this call know about adverse childhood experiences, but I wanted to highlight that concept again in order to talk about how talk about the interplay with acquiring STIs. So exploring the connection between ACEs and poor health outcomes, including STIs in youth, learning about behavioral health treatment options to mitigate risk factors. So how do we respond to kids who we know have ACEs and other risk factors? Identify specific risk factors for STI acquisition in youth, and then discuss integrated prevention and treatment strategies for youth who are at risk for acquiring STIs or for youth who have STIs, in particular, those with HIV. So again, I suspect that this is a review for many, but just to go through the concept of adverse childhood experiences, and for those of you who don't know, for many years, the idea of looking at the impacts of events that happen in the course of childhood that result in long-term impacts for adult outcomes, both and outcomes in all sorts of ways, health outcomes, financial outcomes, ability to be a participatory member of society. There was years of work done to explore what aspects of childhood, in particular negative aspects of childhood, affect all those long-term outcomes. And the concept of adverse childhood experiences over the past 10 years has been introduced as a way to identify specific things that impact childhood development and affect those long-term outcomes. And these are the key adverse childhood experiences that have been identified: emotional abuse, physical abuse, sexual abuse, domestic violence, substance use in the home, mental illness in the home, in particular having a parent with mental illness, parental separation and divorce, having an incarcerated household member, and both emotional and physical neglect. So each of those have been identified as a key adverse childhood experience. And with each of those, it increases the likelihood of having poor outcomes as life progresses. And we'll talk a little bit about the progression of those outcomes. Now, clearly, those are some specific factors, but there are also aggravating factors that worsen the impact of those adverse childhood experiences. Now, I'm sure everyone on this call, you might be looking at this list and you say, well, I had one of those myself. It really is the cumulative effect of the adverse childhood experiences, right? So the more you have, the worse potential projected outcome you might have. But each one is significant in its own right and plays a major factor. So thinking about each individually and how we respond when a youth is exposed to these is key. So looking at the aggravating factors, these also should be considered when thinking about the impact of adverse childhood experiences. These worsen the impact of them. So living in under-resourced, racially segregated neighborhoods, having frequent moves, which is commonly seen in those youth that we know have a lot of instability, moving between different households, moving between different schools, are all known to decrease or to worsen their prognosis and potentially increase the likelihood of poor outcomes across the board. Clearly, food insecurity is an aggravating factor. Systemic racism overall has been identified as an aggravating factor, and limited educational opportunities. So these factors, in combination with those ACEs, amplify the effect that they have when it comes to long-term prognostic outcomes. So here's what they call the ACE pyramid. So you look at sort of systemic issues at the bottom that affect us across the entirety of our society. And then you reach the green areas, right? These are the ones that we've identified as our ACEs. And that's where you begin to see the emergence of long-term impacts to youth, right? So with many of them, as research has shown, you start having disrupted neurodevelopment, particularly with traumatic exposures, with abuse, with neglect, with violence exposure. literally identifiable neurostructural changes to the brain that happen as a result of one time, but more often chronic exposure to those stressors. And this is where our mental health interventions start playing a role because we start seeing social, emotional, and cognitive impairment relatively early in kids who've had a number of ACEs or cumulative effect of ACEs. You see that, again, social, emotional, cognitive impairment, and then this adoption of high risk behaviors, which begins to become most predominant or most prevalent in our adolescent population. And this is where we'll come back to when we talk about risk factors for acquiring STIs and HIV. As things progress, then you see the development of actual disease and potential disability that then really has significant outcomes in terms of the capacity to be successful in the latter parts of your life. And with all of these impacts, it's now been demonstrated that as you have more ACEs, you are actually at risk of early death. So let's talk about why that happens. So with the impact of ACEs, and most of the research is focused on a key number of 4 ACEs. So once you hit about 4 ACEs, the likelihood of all these negative outcomes increases significantly. But again, each having 1 ACE is significant and should be addressed. But it's really that number of 4 that seems to be the critical number that significantly increases the likelihood of these poor outcomes. So, and again, when I said that the research looked at the comprehensive impact of these ACEs, you know, it's clear when you look at the effects that have been identified as potential, again, long-term outcomes. So it looks at financial impact, so poor finances, unstable work history, so inability to sustain work for long periods of time, increased risk of injury overall, and that might be due to engagement in risky behaviors such as criminal activities or violence, but also just the tendency to be in situations where risk of injury is heightened. Incarceration, the risk of incarceration goes up significantly. Substance use problems goes up significantly, but also health problems, and that's physical and emotional. So there's an increased risk of chronic diseases and also poor outcomes in the management of those chronic diseases. So you look at all those things, and hence it gets back to our pyramid, which results again in that early death, increased likelihood of early death for those with a number of ACEs. But specifically for the purposes of this talk, one of a number of the effects that we'll talk about today is the increased likelihood of sexually transmitted infections, increased likelihood of teen pregnancy, and increased likelihood of being absorbed into sex trafficking. So the research is critical in identifying these key ACEs, but also clearly we have to then begin to tailor our response to address these ACEs as they're identified in hopes to mitigate their effect and prevent the likelihood of these poor outcomes. So I have a case example here, and I'm going to ask for some audience participation. You can feel free to come off mute. You can write in the chat, whichever you prefer. But I wanted to present this case example of this kid. And this is a typical kid that I might have seen in the crisis program or I might see in a community clinic, quite normal. But this is a case example of a boy that I created, but again, drew from a lot of my clinical experience. So Jimmy is a 10-year-old boy with behavioral problems. Recently, he's been getting in trouble in school in the neighborhood, so often identified for mental health care for that reason. He's being raised by his grandmother because his mother has problems with addiction and mental illness, and his father is incarcerated. He lived with both parents until he was 4, but there were problems in the home with severe domestic altercations between his parents, as well as drug activity. Jimmy frequently witnessed his father attack his mother. Jimmy was exposed to intrauterine drugs. In addition, in the home in which he was initially raised was in disrepair, and he suffered lead poisoning at the age of 2, all too common in Baltimore and a lot of older East Coast cities. Child Protective Services had to place Jimmy with his grandmother after it was reported that he was being left in the home alone. Jimmy's grandmother is in poor health with chronic medical problems. She struggles to effectively structure or discipline Jimmy. He struggles academically. It's suspected that he has both learning and attention problems, but neither have been investigated by his school despite his problems. He attends a severely underperforming school. So if we can, I'd like to take this opportunity to identify the ACEs that Jimmy has been exposed to or is currently experiencing. So I'd love to hear folks in the audience just kind of shout them out there. What are the ACEs that Jimmy has, thinking about that list that I presented when you're reviewing this case? And again, feel free to come off mute or just put it in the chat.
His mother has problems with addiction, mental illness, father's incarcerated,
Yeah. There's
Emotional neglect.
domestic altercations.
Yep. I see you out there, Rolita. Me and Rolita worked together for a long time, so it's good to see you in the audience. But yes,
There's stuff in the chat too.
Yes.
So parental incarceration, addiction, abuse, violence.
That's right. So all of those add up. Yeah, so it's funny, the issue eater and drugs isn't necessarily an ACE in itself, but clearly is a reflection of that exposure to drug activity, and clearly one of the biological things that impacts him and results in poor outcomes and potential development of a number of problems. So we look at the addiction, we look at the incarceration, we look at the abuse, we look at the parental separation, all those things. Exactly, the lead poisoning, another one of those neurochemical impacts that increase the likelihood of mental health issues and poor educational achievement.
Go ahead, Keith. There's a hand up.
Yeah, good afternoon. It seems like to me he's at risk of repeating all of these things that his parents experienced.
You are absolutely right. So certainly when you've been exposed to all these things, then it develops a pattern, an expectation that you have in your life that this might be the norm, as well as a significant trauma response that unfortunately sometimes results in the repeating of patterns that are quite pathologic. So you are correct in that he might be at risk of repeating all these things. And as the ACE pyramid tells us, right? When you're exposed to abuse, when you have a parent who's been incarcerated, when you have parents who've been separated, then that increases the likelihood of you being incarcerated, right? It increases the likelihood of you having substance use issues. So you're right. That's part of this analysis that early exposure to all these things results in that patterning and that cycle that we too often see, and we try to intervene and break with our interventions. Any other thoughts about the case? Awesome. Thank you for that participation. So here I kind of just highlighted things for you. And this is all the things that you've already called out, right? Mother with problems with addiction, problems with mental illness, father incarcerated, severe domestic altercations, out of home placement, after neglect, situations of neglect, right? Being left alone. You see this one I have in blue, a severely underperforming school, because if you remember, that is one of our aggravating factors, is having poor educational opportunities. So you think about the compounded effect of not having supports, the appropriate supports to potentially mitigate for these ACEs that Jimmy has experienced. Does all that make sense? Awesome. All right. So these next slides really kind of just highlight what we do in the behavioral health field in general. But I wanted to do a quick overview of essentially the entirety of the service line for the public behavioral health system when it comes to the provision of care for children, because I just want to make everyone aware of what is available and how we try to intervene in a variety of ways when we have kids who are having the repercussions of the ACEs that they experienced. So clearly, as you know, we see at the top here, prevention is most critical. Ideally, I would love to be put out of business or have my business significantly reduced by not having to treat the effects of trauma and abuse and neglect and all these sorts of things that too many of our kids are exposed to. So thinking about how we as a society can work to prevent these ACEs from impacting kids in the first place, generally by having early interventions for families that are at risks, or working to treat adults, as they are having kids or even prior to having kids, we can then therefore actually prevent it in the future by not having ACEs or limiting ACEs for kids. We all know that's a much bigger question, how we begin to do that, and clearly a societal question. But in terms of our interventions, once we have kids who are beginning to have those social cognitive impacts as or manifestations of their ACEs, these are the ways we intervene. We have arms of treatment that fall into this crisis care category. The most recent, over the past 5 years, the 988 Suicide and Crisis Lifeline Network, a way to have immediate access to guidance regarding mental health interventions, a single point of contact, where it then diverts to regional management for referral to appropriate resources in Maryland via 8 call centers that manage the 988 hotline. There's also texting available as part of it in case you are unaware, but certainly a great resource to give out for people who might be in need, and a way to easily access and understand how to get attached to mental health services. There are mobile crisis teams. So I talked about my time where I spent working in crisis stabilization services in Baltimore City. Those are available in each jurisdiction in order to provide mobile services for those in need, and hopefully deliver either a one-time intervention or provide services to them, or get them to the right people who can provide the services. If it is needed, there are acute care services, inpatient hospitalization. We all know that I work at Sheppard Pratt, a large child psych provider, for inpatient hospitalizations, partial hospitalization programs, or intensive outpatient programs, which generally are, commonly referred to as day hospitalization programs, where kids or adults might present to a hospital program, get mental health services, and then go home in the afternoon. And they do that for a period of time, sort of an intermediate approach to hospitalization, so that you have potentially decreased costs, that don't have to have someone stay in the hospital if they can be safe at that level of care. In terms of outpatient care, in general, we have therapy services, we have psychiatry services, and that can be delivered in a number of different ways. Outpatient mental health centers is one of the most common ways, especially for kids who are at most risk for having STIs, and including HIV, in large part because they are often heavily in the impoverished population and heavily reliant upon Medicaid. So most outpatient mental health centers are the focus of treatment are those with Medicaid because of the funding for outpatient mental health centers, but also school-based services. There's partnerships for the delivery of mental health services within the school systems. And that's usually partnerships with like OMHCs or other clinics to come into the schools in order to provide therapy and psychiatric services. There are integrated care models, and that one's in red because we're going to come back to that when we specifically are talking about the treatment of kids with co-occurring mental health and HIV. There's group practitioners, there's private pay practitioners. Those are all the ways that we can deliver outpatient services when it comes to providing care for kids. There are also adjunctive services, and these are probably lesser known to those of you who are not directly in the mental health care field, but are ways that we can provide supportive services for youth who might need it, including case management, what we call psychiatric rehabilitation programming. It's often involves like social skills training, anger management training. Therapeutic behavioral services are often in-home services for parents with severely behaviorally disordered kids to help guide the parents on how to better manage them. There's community mentoring and engagement programs. Sometimes can be a nice adjunct to traditional mental health services, or respite services. This is times where you have kids with significant behavioral health problems, and they might need to actually go stay with another family, go stay in a facility for a while in order to provide some respite for their guardian. As things advance with more severe behavioral health issues, there's specialty services such as these specialized therapy programs, multi-systemic therapy, and functional family therapy. And Keith, I see, I'll get you in one sec. Um, Multi-systemic therapy or functional family therapy. These are offered through Department of Juvenile Services or Department of Social Services. They're more expensive and more highly regulated models of care, so they tend to be reserved for those with more significant needs. Substance use services that could be outpatient, inpatient, residential. And then for those at the highest level of need, there's actually residential care that we can provide for those with really significant behavioral health disorders. All right, Keith, I think you had a question.
Yeah, when you talk about group practices, um, could you elaborate on that a little bit? Were you speaking about, for example, like kids participating in some type of like community activities with other peers, like focus on some kind of like therapeutic, psychodynamic, psychoeducational intervention, recreational stuff?
Yeah, that's a really good question. When I'm talking about group practices here, that's just usually a different model of delivering therapy or psychiatry, where you might have a group of clinicians that get together and they form a practice and they're going to deliver the therapy as a team versus a traditional like community clinic that many of us might be more familiar with. Now, what you're talking about is probably more of these adjunctive services. That's where you get that type of more community engaged, recreational, but in a more therapeutic way. So it's not uncommon for kids who are enrolled in psychiatric rehabilitation programming to do community visits and practice again anger management as a group, or talk about social skills and go and work on those social skills in the community. Um, Similarly, those community mentoring or engagement programs do similar things. It might have recreational opportunities after school and things as such. So those ones are a little bit more, I'm going to say gray. I don't know if that's the right term, but that's where the blending between therapeutic and more supportive, mentoring, recreational, this is where those adjunctive services fall. So going back to our case example, we have Jimmy who has all these ACEs, right? And the question is, how would we then treat him? How would we provide care for Jimmy in our sort of public behavioral health model currently? So this is just an example of how we might respond to his needs. So ideally, we might tap some school-based therapy services, those school-based partnerships that I was talking about. So working with a clinician that's based in Jimmy's school, knowing that maybe his grandmother would have more difficulty getting him to traditional clinic services, we could actually utilize a clinician that's in his school in order to provide both therapy and psychiatric services. We would hopefully get Jimmy a psychiatric evaluation and potential treatment, right? We know he's at risk for a number of mental health disorders that might require treatment with medication, especially since he has both a history of intrauterine drug exposure as well as lead poisoning. As Keith was saying, we might want to do some psychiatric rehabilitation programming at this point in order to aid in some behavioral management and social skills training. Since Jimmy's already starting to get in trouble in the neighborhood a little bit, we want to figure out ways to engage him, work on some of that anger management. We'd want to identify some parent support, and this can be done often via family support groups, right? Because we know that grandma is struggling with her own physical issues that result in a limited capacity to respond to Jimmy's needs. So maybe thinking about case management services, or at the very least, some support groups to help her in her capacities to manage Jimmy, and also help to identify her needs that might get in the way of that management. And then if Jimmy's problems escalate, think about crisis intervention or acute services. You can even begin to tap things like specialized schooling or residential care if necessary, but hopefully avoiding those higher levels of care by getting to Jimmy early and using these lower level services to respond to Jimmy's needs. All right, so let's sort of shift, but as you see, it's not that much of a shift to talk about behavioral health and STIs in youth. So certain behavioral risk factors increase the rates of acquiring STIs or increase the tendency for high-risk sexual behaviors. And here, those high-risk sexual behaviors are identified as early initiation of sex, reduced condom use, and a high number of sexual partners. But we can think about a number of other high-risk sexual behaviors that are commonly seen in our youth population. So if you have these things listed below, right, 1, 2, 3, and 4, you are at increased likelihood of acquiring an STI. So if you have a mental health diagnosis, then you are at increased likelihood of acquiring an STI as a youth. And that's not surprising, right? Because you think about the diagnoses that we commonly see in youth, and the common factor with those diagnoses is that often in youth, they result in decreased or increased impulsivity, right? You think about ADHD, attention deficit hyperactivity disorder. You think about early signs of bipolar disorder. You think about even trauma-related disorders. All those things in kids very often present with poor impulse control, poor decision-making, high risk-taking, and that includes high-risk sexual behaviors. So it's not uncommon that these kids engage in these risk behaviors at a higher percentage than quote-unquote typical youth. Again, substance misuse, it's not a huge surprise that kids who are actively using substances have a higher tendency to engage in high-risk sexual behaviors, right? We're talking about more impulsivity, less thoughtfulness about one's actions, even just altered cognitive states, all those sorts of things where, again, that thought process, which is already impaired in youth because their brains aren't fully developed, is further impacted because they have the impacts of substances that further, again, worsen their decision-making, decrease their overall executive functioning, increase their impulsivity, all those sorts of things. Foster care involvement is another risk factor for acquiring STIs in youth. And you think about our foster care population, and most often, like Jimmy, who is near foster care placement, they have this combination of things that make their overall thinking, overall impulse control, overall executive functioning worse than even typical adolescents or kids. Very often they have been traumatized. So as a result of that, they have all that trauma exposure that sometimes leads to high risk taking behaviors. They might have some of those neurochemical impacts like lead poisoning, like intrauterine drug exposure that of course they're at increased risk of because they ended up in the foster care system. All those things affect their decision making and increase the likelihood of them engaging in high risk sexual behaviors. So foster care involvement in its own, on its own, stands as one of those risk factors that increase high-risk sexual behaviors or acquiring STIs in youth. Pretty common for those who've worked with a lot of kids in the foster care system, especially our young girls who've bounced between homes and been sexually, physically abused, emotionally neglected, that a constant discussion about their high-risk sexual behaviors is necessary when providing behavioral health treatment because it's just so frequent that they're making really poor decisions about their sexual practices, either because they have that poor impulse control or they are, having this trauma response that leads them to seek out, love or any sort of emotional connection, and so often, unfortunately, do it through high-risk sexual behaviors. This foreshortened sense of future is one that I added, and hence my asterisk. I don't know that you would find it. You will find it in some of the literature, but it is one that I think in a way summarizes a lot of the issues that we see with youth. And you think about high-risk behaviors in general and how that leads to the acquisition of STIs. And it's so often this foreshortened sense of future that drives a lot of that. And again, that plays into the trauma and the mental illness and all these sorts of things, in large part because a lot of youth that we see who have had these kinds of chaotic upbringings and who've been victimized and traumatized just don't have the capacity to really reflect on their future in a way that a lot of other youth do. And because of that, things that are presented to them they will put little thought into and think about only the short-term impact of it and not the long-term one. And all too often that leads to a problem when you are thinking about engaging in high-risk sexual behaviors. So thinking about the ideal models of care and prevention, and when it comes to prevention, this is what we would love to see. Okay, and you smart people out here in the audience, I task you with helping us all think about how we can achieve this. But when we think about prevention for, especially for these youth who we are able to identify because we know if they have these ACEs in their life, it then leads us to the question, how do we then intervene in order to prevent those poor outcomes? Not only prevent those poor outcomes from a mental health standpoint, but thinking specifically about acquisition of STIs, especially HIV, how do we, once we're able to identify these youths who are at risk because of their backgrounds, how do we prevent them then from going on to acquiring an STI later on? So really, we want to think about integrated treatment for trauma and sexual risk with these identified high risk groups. So this is where we lean upon our primary care clinicians to say, hey, I have this youth who has all these identified risk factors, who has 1, 2, 3, 4, 5 ACEs. How do I then tailor my primary care interventions to then lessen the likelihood of these poor outcomes? Okay, and clearly we think about like, oh, well, maybe I need to get a behavioral health practitioner involved, but how do I specifically target their sexual behaviors when I'm thinking about the care that I'm providing in order to prevent them from acquiring an STI, in particular HIV? Oops, forgive me. So the idea is to combine reproductive, relationship, and mental health as part of therapeutic efforts. And again, this being part of primary care interventions through pediatricians. And maybe there are other professionals that are brought on to assist in this comprehensive approach at prevention. But the idea is you want to address the behaviors, cognitive and emotional, psychological, and social processes that are associated with HIV risk. And then you want to include some evidence-based HIV STI prevention strategies, such as sexual partner communication skills, right? Things that are done relatively commonly in pediatric practices, but should be bolstered when you have kids who are particularly high risk based upon their backgrounds. And then you want to think of incorporating your behavioral health professionals so that you can do some intervention activities that are rooted in principles of cognitive behavioral therapy. And you will see cognitive behavioral therapy come up a lot when it comes to both prevention and treatment of youth with STIs, because it's really about changing some of those really negative thought processes that then impact their behaviors and lead to those higher risk activities, right? Think about that cognition that says, well, I'm never going to move past this point in my life, or I'm doomed, or no one loves me, or no one cares for me, so I might as well, right? You target those negative cognitions that then impact behaviors and hopefully results in the decreased likelihood of them having negative outcomes, such as STIs. Sure, Keith, you have a question?
Yeah, I was just thinking, for youth that are sexually active and are at probable high risk of contracting HIV, etc. And you mentioned about reproductive health. I was thinking about birth control, and I was thinking about PrEP and things like that. Should all of that be introduced to them?
Yeah, so it's funny. When you're thinking about that high risk population, the ideal model is to really combine all those aspects together. And I didn't talk about kind of this reproductive care aspect of it, because clearly that's not my purview. But thinking about when you do introduce all those things to those who you're treating from a pediatric standpoint, and doing it all again together in this comprehensive format. So talking about condom utilization and birth control, and decreasing the number of partners that you expose yourself to, talking about what these relationships mean to you, right? And again, this is why it has to be a number of people working together as a team to cover all these areas, because no one professional can hit it all. But talking about utilization of PrEP and again, decreased partners, and then talking about the emotional aspect of that, why it is that you have such a high number of partners, and how do we link you to a therapist that might be able to address the fact that you are potentially seeking out whatever through sexual interactions. So it ends up being this really comprehensive approach. Again, the ideal model in order to attack the issue from but with a number of strategies. Make sense?
Yes.
Excellent.
I mentioned that too because it's like, working in so many environments like child protective services, and I've seen youth struggling and dealing with all of those kinds of issues that you bring forth.
That's right. Right. And hence why that foster care group ends up being one of the higher risk ones, right? So automatically should be identified, in my opinion, for some of these more comprehensive combination approaches at care. We know that, again, the foster care youth is at a high risk for a number of poor outcomes, but especially for HIV and other poor health outcomes. So the goal is, again, for these ideal models of care, how do we then know we've identified them, and then work to create this comprehensive team approach to address the issue from a number of different vantage points, including reproductive health, relationship health, and mental health all together. So specifically thinking about youth with HIV and mental illness, the literature is clear that even with a lack of premorbid illness, meaning even without having a mental health diagnosis prior to the acquisition of HIV, just having HIV increases the risk of developing mental health problems. And there's a number of sort of neurobiologic reasons why that happens, autoimmune issues, all these sorts of things that result in the increased likelihood of having a mental health diagnosis just because you acquired HIV. But as we've been discussing, a lot of youth who end up acquiring HIV already have all these problems anyway, right? All these problems increase the likelihood that they're going to get HIV. So we're starting at a baseline that is already problematic, and then HIV in itself can then increase the likelihood of acquiring a disease and certainly increase the severity of a pre-existing mental health issue. And as I've hopefully made clear, the factors that increase the risk of acquiring HIV are often the same ones that reduce treatment success, right? You think about those ACEs and how that potentially results in early death. And it's because all those things get in the way of successful treatment. All those mental health issues, all those cognitive distortions, all of those adoption of these problematic behaviors or patterns then reduce the effectiveness of treatment, or it reduces your ability to access treatment. So impairment in mental health for youth with HIV leads to negative health outcomes in general and overall worse prognosis. And that is from beginning to end. So youth with mental health issues have a delayed diagnosis of HIV, and all the way up to the end, which hopefully would be achieved viral suppression for those who acquire HIV, they're at a decreased likelihood of achieving viral suppression. And why? Because they have worse antiretroviral adherence. They have delayed or failed viral suppression. And overall, they have a higher mortality rate because, again, all those issues that we've been talking about get in the way of their success when it comes to treatment for HIV. So how do we then tackle this? How do we combine what we know about the risk factors for getting HIV? How do we combine treatment when it comes to the fact that we know that those with mental health issues have a worse outcome? How do we address that specifically? So first and foremost, we have to have universal mental health screening as part of ongoing HIV care. So I know the experts that are doing this work, it is standard practice that they are doing continuous mental health screening as part of just the delivery of care for those who have HIV. So that way we can intervene early with early identification of problems that arise. And then similarly to the prevention strategy, we want to work at an integrated approach for mental health care into HIV care. Again, working collaboratively so that you're not going across systems and going across providers and having delays or disruption in care because you're working to connect people to their appropriate, provider, is all eliminated if we can work on integrated models of care. Okay, with the appropriate resources to address the gaps too. Of course, we need the resources to address gaps in screening as well as resources to address treatment gaps. And there's a couple I'm just highlighting here, these sort of integrated models that can be useful strategies when thinking about how do we get behavioral health care into primary care or into specialized care for those with HIV. There's this primary care behavioral health model, which essentially has primary care clinicians hire or have a behavioral healthcare professional as part of their staff. So you literally have access to that behavioral healthcare professional within your practice. And then there are newer models that are evidence-based and are reimbursable now through Medicaid and Medicare, including the collaborative care model here, which essentially sets up a relatively intensive consultative service that exists outside of primary care practice, but is available to any person that is needed for this consultation, and includes both therapy consultation, assessment consultation, and even psychiatric care consultation. And again, it's reimbursable through somatic billing, so through the somatic provider, but offers a way to access behavioral healthcare teams in this more consultative approach. And then my last slide talks about specific psychotherapies for youth with HIV. So thinking about what do we do? How do we tailor our therapy approaches for those with HIV? And there's been some studies that look at all the therapeutic approaches. I'm using that word therapy broadly because some of them aren't traditional psychotherapy, but also some psychoeducational aspects of care, and looking at what's most effective when it comes to treating youth and their families who might be impacted by HIV. And most of the studies show that the combination, again, health and wellness education in combination with psychotherapies end up being the most useful strategies for treating youth with HIV, and decrease the likelihood of those poor outcomes that we talked about, such as poor antiretroviral adherence or delayed viral suppression. When you combine health and wellness education in combination with some traditional psychotherapies, you get the best outcomes in terms of improving the outcomes for HIV care overall. Cognitive behavioral therapy, as I said, ends up being kind of the most studied and has the most evidence-based about specific therapy interventions when it comes to youth with HIV. And that can include traditional cognitive behavioral therapy that talks about that triad of thought, of cognitions, behaviors, and emotions. There, I almost got a little lost there. So emotions, behaviors, and cognitions, and how those three interplay, and working on disrupting that triad to change any of those three components of it. But also some mindfulness interventions are key too, and have been studied with pretty good effectiveness when treating youth with HIV. Basic things like motivational interviewing, has its roots in substance use treatment, but is used broadly in a lot of mental health interventions now. So thinking about motivational interviewing, going through with youth and saying, hey, let's talk about how those behaviors are impacting you right now. Like, what do you hope to gain, and how are the things you're doing currently getting in the way of that goal? How is it that your poor adherence to your medication is impacting your ability to go out and have fun on the weekends, or things like that, right? It's that sort of more basic analysis in order to help motivate the behaviors that you want to see. And then lastly, it is very important to understand that just like most interventions when it comes to child mental health services, when working with youth with HIV, it is critical that family-based interventions are high priority. We know that working with youth, when you treat the family, you have greater success almost across the board when you can include the family as part of that interventions. And for youth with HIV, that's also including things that we might not necessarily think of, such as finance management, right? social integration. So thinking about working with families about how you address issues with the fact that you have an HIV positive youth and having them successfully integrate despite that. And then overall psychoeducational approaches with families. So again, these are the psychotherapies that have been studied most to be most effective for youth with HIV. So when you have therapists that are doing the work with those kids, thinking they will often think about these strategies, or even you helping to educate folks when thinking about all these ways to best form psychotherapy for youth with HIV. Last but not least, references. Um, And that is all. I would love to have an opportunity to open up the last 5 minutes for some discussion and answer any questions that you might have.
Well, thank you so much. That's super comprehensive. Of course, there's already questions in the chat. So there's one from Lauren Gordon who's asking, and I think a question that many of us probably think about is, how do you integrate mental health care when patients do not have insurance, are not eligible for insurance, and particularly with what we're seeing now with insurance sort of at threat. What are your thoughts or recommendations to providers?
Yeah, it is a huge challenge, I have to admit. Many of the services in the public behavioral health arm right now are available for those, even those without insurance. So especially the crisis services, that is part of the mission for the creation of crisis services, is really to allow access to anyone and everyone. And mental health services, for many of you know, get a little tricky because so often, there's differences. If you have commercial insurances and you have, Medicaid or Medicare, and this provider can't see you and this one can, that's especially more pronounced when it comes to behavioral healthcare services. But when it comes to those really acute services, especially crisis services, most often they can be accessed even without insurance. Beyond that, it is unfortunately cobbling together the way that we all do, and we're trying to figure out how to provide care for those without insurance. Thinking about our clinics that have some grant to provide care for those without insurance. We're working at some of our, looking at some of our um, our public funded clinics and things like that. They're often through um, the city or things like that. It's a challenge. I don't have a great answer other than at least crisis services you can access without having insurance.
I was reflecting on your case because I think, certainly we see those kids and they're compounding those ACEs, and then sometimes there's a slow march towards one bad thing and then it compounds the other bad thing. And when it comes to sexual activity and HIV, I also worry that the kids who then develop mental health issues are also at higher risk of being abused on top of that. So it's this vicious loop that happens. I guess my question is, given Lauren's question about access to mental health and us providers, primary care and the like, who are on the front lines, wondering what, if you had to recommend, sort of, what are the things that providers can do themselves in terms of skills or things that you suggest developing, in addition to, of course, knowing what resources? What are some skills you'd say, learn these few things that they may help you to either identify it or to refer or to take care of you until you can get them to someplace else?
Yeah, no, that's a great question. I think it depends on which provider you're talking about, because I think the messaging is probably the same. The what I would say is the same, but the messaging that I would want the different provider to give would be different. So I think in terms of our behavioral healthcare providers, we have to have more robust, frequent, almost continuous conversation about sexual behaviors, especially for our high-risk youth. And ideally, even when it comes to earlier interventions, I mean, there's so much I was talking about in terms of identifying these youth young, because we know that they've had these ACEs right from the beginning, right? So let's tap them early. Let's start asking these questions. Let's start doing this psychoeducation early before the onset of these really high-risk behaviors. Now, for the somatic providers, the question arsenal has to be different, right? Because I'm hoping that you're doing a robust effort in terms of talking about sexual health, but often not as much of a thorough discussion about behavioral health. So having as part of your toolkit those frequent questions about, let's talk about what you've been through and how that impacts you, right? And clearly you want to do this in a screening way. And I think there's standardized screening that gets extraordinarily useful and is rolled out for the most of primary care at this point. But incorporating that as part of your well child visits, as part of your specialized care when it comes to HIV treatment, I know you've been through a lot. Let's talk about how that impacts your behaviors. Do you think you want to address these sorts of things with, if I can get you to somebody, would you like to talk to somebody about it? And that way we can, even if we can't provide the comprehensive care that I presented in those ideal models, we can at least all work on the same page about connecting with each other, even if we have to have a little more effort to do so.
No, that's helpful. I don't want to monopolize. Any other questions for Dr. Means? This is fantastic, by the way, Dr. Means. Other
Thank you.
questions or comments?
Yeah,
Toya,
I
you see Toya's question?
Yeah, I see it. That's a very good question. It's a tricky balance, and I actually this is one of the things I actually enjoy quite a bit. I really like working with teenagers in particular. It's a little harder when the kids are little, but often when the kids are little, they're having such significant behavioral issues that families tend to be a little bit more engaged because it's causing them some consternation, their behavioral issues. But for adolescents, there is a period where you might have those who are demonstrating the need for behavioral health interventions and seeking it out, and they have families who are not as engaged. And for mental health professionals, especially those who treat older adolescents, there is a way that you can begin to engage youth and talk about the fact that you are developing into adulthood. And part of that development means some separation from parents, or understanding that there's aspects of your parents that are just human being stuff that they get wrong, right? It's actually an intervention that a lot of mental health care professionals do with older adolescents, and one that I enjoy a lot because it allows, I think, those even adolescents with mental health issues who might be a little bit behind the eight ball emotionally, it pushes them forward through that natural stage of development that happens with most of us as we begin to get some differentiation from our parents and our families. And often excites them in a way, right? Because they get to see, like, I'm becoming an adult, and as part of that, I can start reaching for things on my own, even things that are helpful, even other things that my family might not approve of.
Just to piggyback on that question, when we look at HIV and STIs, there are huge disparities in with Black and Brown youth in particular, having higher rates of both of those. And traditionally, Black and Brown communities are often really anti-mental health interventions, right? No, I'm not crazy, quote unquote. My sense is that we as a society are talking more about mental health, and wondering if, for what you've seen from youth, do you feel as if the acceptance for mental health interventions has increased or access, ability or desire to access has increased among youth? Is that your sense?
Absolutely.
Yeah.
Absolutely. It's getting better. I mean, it's still not where it should be, and certainly
Mhm.
that stigma and that bias is present, but having open discussions, having treatment providers who are Black and Brown is great because they can communicate in a way that breaks down some of those walls. There is so much more discussion that's happening, which really excites me. I just sat on a panel for Men's Mental Health Awareness Month, specifically looking at Black men, and having these open discussions about Black men being in therapy and people having their own personal accounts was really heartening, and it shows the progress that we've made even over the past 20 years since I've been in the field. It's really great to see, and I think we are headed in the right direction.
Well, with that, it is 1 o'clock. Thank you so much for this. So just so you know what happens after that, you'll be forever on YouTube, on our channel, so people can access it, and people
Or
do
YouTube.
access after the fact. If people want to refer to you or reach out to you, would you be willing to share your info in the chat, or how to best refer
Absolutely.
to you?
Absolutely. Sure.
And we'll go from there. Thank you so much. And we have more that we may want to bring you back for. So hopefully we could do that. That was really, really fantastic.
I enjoyed it as well. Thank you for having me.
Thanks so much. And we'll share that when we share the link to the YouTube. All right. Take care, Dr. Means. Thank you, everybody. Bye-bye.